I was just about to say, if you could record that, that would be great, because I don't trust this computer right now. In any case, so dealing with oxygenation, ARDS, ARF, not like the dog, but the respiratory failure, and mechanical ventilation. So starting this off, we just have our regular oxygenation assessment. So you have your early and your late findings. We don't want to get to the late findings. So we'll have to identify early signs and symptoms first and do our interventions at that point. So neurologically, what are some early findings you will see if your oxygenation is poor? Altered level of consciousness, confused. Yeah, and then this could be one of the first signs. So just be aware of that. Where's the underline? There it is. Agitation as well. So any like random mentation changes, restless as well. Oh God, how do I restless? There we go. Let's see. So if they have any acute confusion and restlessness, you need to be looking at that. Investigated. I don't know how you type and talk so well. I cannot do it. Okay, let's see what else we got here. Cap refill, longer cap refill for cardiac, yeah. So longer cap refill. Tachypnea for respiratory findings. Oh God, how do I spell? Tachypnea, sure. Okay, tachycardia for cardiac. But yeah, with that tachypnea, they're going to be shortness of breath. Let's see. Along with that, maybe change in positioning. That's the word I was looking for. I forgot the word for it. Delayed cap refill. So greater than 3 seconds. I was like, what is the word for it? I'm so bad with the words recently. I'm not sure why. Yeah, cyanosis is definitely one of your late signs. So that's a big bad. That is the big bad. Central cyanosis especially. But we'll get into that one in a second too. Like that scene from, was it Charlie and the Chocolate Factory? But I know the girl was like chewing gum, but she turned all blue. Like that's what I think about when I think central cyanosis. Good times. But yeah, so for skin, you could be pale or dusky. That's definitely something that could happen. That's not how you spell dusky. Okay, and then cool and diaphoretic as well. Let's see, where are we at? Tachypnea, I was up here. Okay. So obviously if you have tachypnea, change in positioning, you're going to see some accessory muscle use as they're trying to compensate, and then possibly a new onset cough with secretion. Yeah, so early on. I'll try to see if I can like maybe I'll bold this one. Go. Because all of this is early and this one's late down here. I've been jumping back and forth a little bit. Cardiac findings that are early. You have the tachycardia. You could also have palpitations. And then you can end up going into AFib or a flutter due to the lack of oxygenation. In terms of labs, oops, there we go. You'll have an H&H decrease, it's essentially anemia. Skin, I think the only thing missing from here is mucous membranes, dry and pale, kind of with pale and dusky appearance in general. Our late findings, I think Josh said cyanosis, so that's a big one. And then you can also have that altered level of consciousness, but to a worse degree. So the word that you're going to see is somnolent, aka they're like really messed up, really hard to arouse. Like you'll be talking to them and they'll just like stop talking you mid-sentence. So that's not good. Loss of energy. Yeah, if somebody's not able to get enough oxygenation going around, they're not able to get enough oxygen in, they're going to be very tired. They can't do all their metabolic processes. And then worst of worst is when your compensatory mechanisms fail. Compensatory mechanisms. So what does that look like? What two vital signs specifically? Yeah, so you'll have bradycardia, probably would have hypotension as well. Oops, respiratory depression. So that one's gonna be a big one. I wouldn't surprise me if hypotension happens as well. I would just assume everything goes down, but the one specifically noted for you guys was respiratory depression and bradycardia. Okay. So going on to some interventions, if we have, we recognize the early signs and symptoms, we want to go and intervene early just to make sure that we don't get into, cyanotic territory, somnolent territory. So for early interventions, what does that look like? Yeah, change of position, head of bed up. Oops. Supplementary, that's not how you spell that. Supplement. Is that how you spell that? There we go. Yep. IS and turn, cough, deep breathe as well. Thank you for fixing my typing errors. I appreciate it. I'm really struggling to type. I'm so sorry. Okay. Let's see. Possible breathing treatments as well. Sure, definitely depends on what's going on. So, um, possibly doing steroids, like if we have someone with a really bad asthma attack, steroids or the rescue inhalers, antibiotics if there's an underlying pathology going on there, bronchodilators. Let's see, suctioning. I like the idea of that if there's something going on where they're not able to breathe properly, due to secretions blocking up all that airway. Definitely makes sense. Yeah. I'm not sure if I would go too much for ambulation though. That would be the fear. Make sure they actually have oxygen in it. I have a really short, funny story on that because for first and second semester, they're doing like a CJM form thing, and they have like a patient that they're doing like this whole evolving case study on. I'm the patient. So they recorded a video of me and they put the nasal cannula on me and they turned the air on and I didn't like the way it felt. So I like pulled it out so it's like half hanging on my lip and I'm trying to make sure that as I'm talking it's not falling off. So it just looks really dumb. But yeah, I get why people take the nasal cannula off because it is very uncomfortable. I did not like it. I would be a horrible patient. Forgive me. But yeah, making sure that they're making sure that they actually have oxygen on. Is it actually on and then on their person as well? Because they might take it off, especially if they are confused. If they were confused due to lack of oxygen, they might just rip it off. They don't like the way it feels.
They might also like have it on. Like the O2 might be on, it's actually on the person, but they're breathing through their mouth. Like a lot of COPD people breathe through their mouth. So having the nasal cannula might not do anything because they're not even using their nose.
Not, yeah. Especially those, if they are having tachypnea, a lot of times you don't see them breathing their nose, breathing through their mouth, trying to get more in. So that would make sense at that point, possibly changing it to another form of supplemental oxygen as opposed to nasal cannula. Let's see, what else are we missing? Oh, how often are you doing your vital signs? I mean, honestly, it probably should be more often than what was stated here, but yeah, I was like, I could be often. Q4 technically or more as needed. I would definitely advocate for their patients decompensating, but maybe that's just me. Um, Alongside of that, looking how often are we increasing their supplementary oxygen? If we're having to bump it up 1 liter every hour and they're not doing like once oxygen is on them, they're higher acuity. Very technically, yeah. If there's a lot of changes going on, so are we increasing it constantly? Like they're becoming, yeah, it depends how they're responding. Sometimes you slap 2 liters on someone and then they're totally chill. Sometimes you slap 2 liters on someone and they're still decompensating. So looking at how they're progressing, you put it on, you reassess them. Are we getting better? Are we getting worse? That's going to change your acuity level there as well. Along with your assessments, you should be assessing neuro and that's not how you spell neuro. That's not even close. Neuro and lung sounds. That should be lungs Q4 hours. Neuro, I'm trying to remember on regular floors. I believe neuro is, Diego, correct me if I'm wrong. Is neuro Q4 or Q shift on regular floors?
On like a med search floor,
Yeah.
unless they have something, they don't even have them.
Yeah, I was like, I think it depends. I've seen different orders, but it's been a hot second since
Yeah,
I've had to think about this actively.
I've seen Q1 or Q4, I think.
I've seen I've seen Q1 on pretty much everyone who's in the ICU, and then on regular floor, like on telemetry, I remember seeing, I think it was like Q shift or PRN if something changes, if you think that something's changing, something
Yeah,
like
I
that.
haven't seen it very often, but when I was on the stroke neuro floor, it was either like one or Q1 or Q4. But that floor again, it was more like med surg overflow, and then like two or three stroke patients, neuro patients. So
Gotcha.
there's that disparity. And then when it was in the DOU, I think the DOU is again just I've seen Q1, Q4. Uh, but yeah, med surg, I think I've seen either Q4 or nothing.
Got it. Cool beans. Oh yeah, so a lot of your interventions here is basically to make sure that they don't progress. So if all your interventions fail and they progress, what are we looking at now? I mean, other than late oxygenation signs and symptoms. What is the ultimate consequence of this? That's definitely one of the consequences of that. Refractory hypoxemia, and in particular, just, I mean, generally respiratory failure, which we'll go into the next section down here. I'm trying to keep up on what Diego's showing on this side to make sure it matches up. There we go. Okay. So onto acute respiratory failure, also known as ARF. This was basically just you're not able to, that's not how you spell that, to have adequate gas exchange. Um, so you either end up with hypoxemia or hypercapnia. That's referring more to ARDS, so that's a different disease process than your acute respiratory failure. So fair warning on that one, because it does get a little confusing. Your acute respiratory failure is broken down into two parts as well. So you have a ventilatory failure and your oxygenation failure. Once we get talking into the oxygenation failure, ARDS is an example. Oh, okay, gotcha. Um, for oxygenation failure, ARDS falls under that category. Um, it was kind of confusing. I remember having to look it up a lot and getting really turned around when I was trying to study for this test. I was like, let's see. Oh, here we go. So just a mini overview of labs because ABGs are going to be really important when you're dealing with anything respiratory wise. Um, Hypoxemia will be shown as what? Like what value? I don't know who this person is, but they're not for me. Yeah. What specific part of your ABG are you looking at? Yeah, your PaO2 for hypoxemia. So a PaO2 of less than 60 would be hypoxemia, and then your normal range is 80 to 100. So as we see, there's a pretty big disparity there. It's not, she ain't doing too hot. Hypercapnia is when you get into your CO2. Oop, that's not how you do that. That's when you get into your CO2. So at what value is it considered like hypercapnia? Technically over 45. I would say over 45. In your lecture, you guys were set over 50, but your normal range is 35 to 45. Oops, that's not how you do that. 35 to 45. So I could see also how in some facilities over 45 would automatically be hypercapnia. So that's your mini overview. Those would be the main points I would know. Knowing how to interpret your pH, what's acidic, what's your compensatory mechanism, um, or what else specifically for ABGs? Oh, my internet is unstable. God help me. Well, If for some reason my Zoom cuts out, pray for me. It is still raining. I forgot about that. I haven't been outside in a hot second, so I don't really know what's going on anymore. Okay. So your ventilatory failure now, looking at like a general overview of ventilatory failure, it's essentially dealing with the hypoventilation. So there's a couple different causes for that. I should probably change that to up here, but it's okay. Um, your hypoventilation leads into hypercapnia, which we referred to up here, PaCO2 over 45 or 50, depending on where you're looking. And hypoxemia and respiratory acidosis. Yeah, or alkalosis, then progressing to acidosis. That's not how you spell this. I'm so bad at typing this at the same time. This is not working very well for me. So what are your signs and symptoms of your ventilatory failure? I mean, we kind of went over some of them. Oh, we'll just talk about it. I think the causes are going to be more important in this section. So you'll see somnolence, a low respiratory rate and effort, um, diminished tidal volume, and diminished breaths. That's not how you spell that. Diminished breaths. And then looking into your causes, yeah, definitely that sleepy. That's your somnolent. What are some causes of ventilatory failure in specific? And there's quite a few of them. Narcotic overdose is definitely one. That's not how you spell that. Narcotic overdose, a blunt trauma, head trauma, tidal calculated with, oh God. Let me look that one back up. Give me a second to look at that.
6 to 8 ml per kilogram.
Okay, I'm glad you got that because I was like, ooh, I haven't had a look at that in a long time. Let's see, where am I at? Head trauma, SCI as well. Where are we at? SCI, TBIs, that goes with your head trauma. So there's a lot of these. I mean, overall, MS is another one. I think the general thing that you need to know is that this person cannot move, like they can't move air in and out. So it's a problem with how they're breathing. So that blunt chest trauma, I should probably say blunt chest. There we go. That blunt chest trauma, it's to the point where there's some kind of restriction. Narcotic overdose, their tidal volume is really low and the respiratory rate's low. MS, weakness. Head trauma alters how you're breathing, your effort of breathing. All of this is due with not being able to move enough air in and out of your persons. So there's a lot of different causes for that. I would just know, some main ones. I think narcotic overdose, your blunt chest trauma, head traumas, any disease process that could cause like a muscle weakness. So your muscular dystrophy, ALS, um, and alongside of head trauma, I just realized I didn't put this. Increased ICP is going to be a big one. So if you have someone with like a hemorrhagic stroke, tumor, or again, that blunt head trauma, then you're going to have increased ICP, which puts pressure on the respiratory control center, which is somewhere in the brain, I'm sure, and depresses your respiratory drive. Is that all for this section? I feel like that's all. Is there anything you want to add, Diego? I just realized I haven't been asking you nothing.
I don't think so for now.
Okay.
Let me actually kind of read back out everything to see
He
if there's
hasn't been
anything.
paying attention to me. I'm just messing with you.
Um, that seems fine. Yeah, blunt trauma, head trauma. Yeah, everything seems good.
Cool beans. So then going into the other type of failure, your oxygenation failure. Um, this one specifically is dealing with bronchioles or alveoli that cannot diffuse O2. So this is a problem that's deeper inside. It's not a
Bronchioles.
problem. Yes, bronchioles. Um, It's not a problem with they can't get enough air in and out. On these people, you're going to actually see them, really struggling. They're using their accessory muscles. They're like breathing pretty deep, but the issue is further down. They're not able to have that blood gas exchange down at that level. And this one's so much more dangerous. So let's see. I kind of went into some of the signs and symptoms, causes of that. So anything with damaged alveoli, anything with oh geez, with damaged alveoli. ARDS is definitely that example. That's not how you spell this. Come on, Bayron. There we go. ARDS is one of them. COVID and pneumonia. COVID was a really big one as of more recently. And COVID ended up leading many people in. So that's why, when all that news was coming out and they were like, oh, we're seeing all this like white ground glass appearance on it, they were going into ARDS. COPD can have oxygenation failure as well and be more associated with ventilatory failure. Thanks. I realize um I misread on the notes side COVID as COPD because I don't have my glasses on, so I misread that. My bad, Chief. That was my bad. Uh let's see. And pneumonia, ARDS, any kind of acute lung injury, so maybe some kind of burn, sepsis, cancer I saw, and then that PE as well. Let's see, signs and symptoms. I talked a bit about some of them. That high respiratory rate. Ventilation does not necessarily mean bradypnea. They might be trying really hard to breathe. So they're tachypnea with low ventilation. Thanks. Where was I at? Okay. High respiratory rate, tachypnea, dyspneic, sure. Confused and restless, uh, going into those early oxygenation and God forbid those lower ones. They're going to look a little dusky. Accessory muscle use as well. And then here's the big one with your oxygenation failure. Will benefit with BiPAP to open up alveoli so oxygen can get in. Depending on the pathology, but that's one of the treatments that could be available. That's definitely correct. Your big one with your oxygenation failure is that their SAT-O2 will not maintain even with O2 supplementation. So that's going into your refractory hypoxemia at that point. I think with BiPAP, I think it's more than poor alveoli. I think BiPAP would be more effective, definitely gearing up for intubation. You're correct on that. It's like that bridge. So it's like, okay, we need to set up for intubation. We'll get BiPAP in here real quick, just so we have this window of time when it deals with your oxygenation failure. I feel like your BiPAP might be more beneficial for somebody with ventilatory failure. Your oxygenation failure, it's just kind of like a losing battle. And there's not much that could be done at one point or another, unfortunately. But BiPAP is definitely a bridge. Hopefully it doesn't progress further into it, but intubation is more likely with your oxygenation failure as well. Kind of just talked on this one already. Let's see. Refractory hypoxemia. So what is this? This is hypoxemia. It's a lot of random stuff. Where am I at? Diego, help me. I forgot where I was at.
Re
I see you on here, but
refractory hypoxia.
I can't find the value for it on the note side.
Oh, on that side.
Yeah, I'm trying to find the value for it.
You go on the mini
Oh,
overview.
go in where?
You're there already.
Here?
Yeah, the mini overview right here.
Okay. Thank you. Thanks, Queen. Okay, here we go. So referring to a condition where the low blood oxygen level does not improve despite your supplemental oxygen and appropriate treatment. What did I mean by process? I don't know. Don't really know what I meant by process there. But yeah, specifically, I think, yeah, Josh said less than 60. So when you're PaO2 is, or yeah, PaO2 is less than 60 and they're receiving greater than 60% of fraction of inspired oxygen. That's when it's considered refractory hypoxia. I believe they can also be considered the 50-50 or 60-60 rule. So these numbers could be either 50-50 or 60-60 like we have here. I think that depends on your facility.
I think this is what you meant by process, so I'll write it down.
I was like, I did this.
So
Oh,
hypox leads to hypoxemia. Um, your cells start to shift from aerobic to anaerobic. So that's when you start having lactic acid buildup, metabolic acidosis, organ dysfunction, and death, something like that. Maybe I think that's what you're trying to get at.
refractory hypoxia and refractory hypoxemia, the same thing. Sure, right? Diego?
Effectively, yeah.
Effectively the same thing.
One is hypoxia, one is hypoxemia. So hypoxia meaning lack of O2, hypoxemia means lack of O2 in the cells. Technically, hypoxemia is kind of like a worse thing. So you can be hypoxic. You could have your SAT-O2 be, you could have your O2 decreasing, but your cells still have something going on. Um, Kind of like, yeah, exactly. So kind of like if you remember during your hemodynamics, you have your mixed venous O2. So even through like a full cycle, your body's coming back to get more O2 from the into the lungs, but there's still a percentage of O2 in the blood there. So you kind of have like a very tiny uh like slight reserve, I guess, for a little bit. So it's not like as soon as you stop breathing, you're automatically hypoxemic, right? Yeah, kind of, yeah. So like,
Makes
yeah,
sense.
yeah, kind of like what I was saying. Like if you stop breathing for a little bit, you're not gonna become automatically you're not gonna automatically start anaerobic. You have some stuff that's still kind of there. So hypoxia leads to hypoxemia.
Thank you. So with this in mind, with your refractory hypoxia leading to hypoxemia, there's so many EMIAs, and stuff in here, I'm getting confused. If I'm unable to maintain oxygen levels despite having them get adequate levels of supplemental oxygen, what do you think this will effectively lead to? In a short term, sure, we could get some acidosis going in there. What is like yeah, I was like, the worst of the worst thing that's gonna happen to this patient is they're gonna fall into a respiratory arrest. And then progressing that probably into a cardiac arrest, and then we're gonna have to make some arrangements after that. Um, so that's not fun. Let's see. Now into ARDS. Now talking about acute respiratory distress syndrome, which falls under your oxygenation failure part. What exactly is ARDS? How would you describe ARDS? Oh, there's definitely some infiltrates. Yeah, so we have a lot, not some. You have a lot of inflammation in the lungs, your infiltrates, leading into hypoxemia and distress, probably respiratory failure if it continues on, or respiratory arrest, excuse me. Let's see, process that occurs. Diego, do you know what I meant by process that occurs?
The
Because I
staging.
don't. Staging's down here.
Oh, then not sure.
Oh my gosh. God help me. Because I was like, I don't see what I meant by
Maybe
that.
that.
That kind of goes over in the staging though, so I'm not sure why I put that there.
I don't know. You wrote it.
Yeah, well, I did this like 2 weeks ago. Forgive me. It's been a busy few weeks. Okay.
Seem not slightly.
Okay. Yep, no. Okay. Your main signs and symptoms of this would be your refractory hypoxemia, VQ mismatch, which basically means your gas exchange is very poor, and pulmonary edema with those infiltrates. Um, Definitely those white out on the X-ray, on the chest X-ray. Looks like those lungs got hotboxed. I love that. Wait, oh my God, that's great. That low PO2 paired with a high PaCO2 as well. I'm losing it on the hot box, I'm sorry. Isn't it pulmonary edema from a non-cardiac condition? I mean, essentially, yeah.
Yes, in this case. The
Yeah.
pulmonary edema here is due to oncotic changes in oncotic pressure due to the inflammation. So it's a bit different
Ugh.
compared to the cardiopulmonary or the cardio process, which is due to hydrostatic pressure. So I believe with the ARDS, it's possible you don't get like crackles initially. It's interstitial, and then eventually it makes its way into the lungs. Um, while the cardio part is kind of like you have so much fluid, it has to go somewhere, kind of makes its way into the alveoli kind of right away. So you can have pulmonary edema regardless, but the different way that it builds represents itself a bit different. At least at the initial, and then eventually it kind of makes its way into the alveoli.
I have such like a dumbed down way of thinking about this. That's the scientific way of thinking about this. That's probably the better way to learn this. I learned it as like, well, your heart conditions, your cardiac conditions causing pulmonary edema is from too much pressure and the hose starts leaking. Like that's how I think about it in my head. Versus this, they're just leaky because they're already damaged. But I'm not sure if that helps anybody, but that helps me. And that kind of goes into, one of our signs and symptoms, which we'll talk about later when we get into pulmonary wedge pressure and why it's the values that it is. But we'll get to that in a moment. In terms of some of your causes for ARDS, what are some causes that you can think of, and what's the most common cause? Ouch. Abnormal lung sounds are not heard on auscultation because the edema occurs first in the interstitial spaces and not the airways. Yeah, Dico said something something interstitial. That sound right with his logic. I'm sure of it.
Yeah,
So a direct lung injury, that could be an infectious or non-infectious cause. Oh gosh, there's so many people. Near drowning is one of them. Aspiration is another. That's not how you, apparently a non-infectious is one word. Sepsis is your main cause. So whenever you have someone with sepsis, septic shock, just be aware that they can very easily go into ARDS due to this big ol' inflammatory process that's going on. Because remember that the ARDS definition is it's a widespread inflammation in the lung. So we already have a huge inflammatory and cytokine response dealing with sepsis and septic shock. So it kind of lines up on in that aspect. Uh, where did I leave off? Cancer. Cancer. Pretty sure that falls under biochemical. Where am I at? I was supposed to be there. There we go. So cancer. It wouldn't surprise me if maybe like a pneumonia could go into that. Sure. That drowning or near drowning, sepsis, inhalation of chemicals, chemicals. Yeah, pancreatitis as well. Oh, girl, she got that back from 232. Girl. Yeah, so that pancreatitis, when all that gunk is living in LA. Yeah, with everything that's been going on recently, maybe we might be seeing some weird respiratory stuff go on in recent times, but pray, pray, y'all. But yeah, that pancreatitis, when you have that leaking of the pancreatic enzymes that starts eating up into the, wouldn't surprise me if TB was there as well. I don't think it was specifically noted for you guys, but it genuinely wouldn't surprise me if TB was part of this. I'm sure it would be. What do you think, Diego?
Makes sense. It's an infection. It can cause infiltrates and it can lead to sepsis. Or kind of makes sense. Kind of goes
Makes
together.
sense. Yeah, I was like, I think on X-ray, it's more like when you look at it, it's like a little ball though of white. It's that I forgot what they called it. In my head, it's
The cat,
cheesy.
the caseous necrosis. So you're causing damage for sure. So makes sense. Yeah.
I really Cassius?
Caseous. Yeah.
I genuinely thought of it as cheesy this whole time.
That's what he says. He says it's a cheesy
Yeah.
necrosis.
So in my head, it's just like a white patch of cheese in an X-ray, but I, who knows anymore? Sorry, forgive me. Guillain-Barré syndrome, mm, GBS for ARDS. Diego, help. Assistance.
ARDS. So Guillain-Barré syndrome
Apparently so, right?
would be more like a ventilatory thing rather than an
Okay.
inflammatory thing.
It's on Brooks' PowerPoint.
That's interesting. I'm gonna look it up while you continue.
Okay, that'd be great. Because I was like, I was thinking the same thing just because we have the rising paralysis. So when you get to that point, you're not able to move air in and out. So I was thinking more ventilatory failure as opposed to oxygenation. Um, but yeah, while he's looking that up, I'll talk a bit about some of the risk factors. So any kind of chronic lung disease, smoking, let's just cause more. Oh, well, the question was, what vent do you use? However, I see notes at risk for ARDS. Hmm. Yeah, I'm not.
Maybe because if they're having trouble kind of moving around, they're paralyzed, they're also having trouble getting stuff out of their lungs, and then they have risk for a pneumonia, and then pneumonia leads to ARDS. But I would imagine they have a higher risk of ventilatory ARF than anything. But I think you could still kind of that's kind of where that would come from, I think.
I could see where the progression of that is. Honestly, I don't remember because I think we had two PowerPoints and I think I used Rydell's old PowerPoint over anything else. So I have more notes on hers.
Yeah.
Um,
Because like if they're on ventilators, they could get ventilator pneumonia, they could get aspiration pneumonia, and then that can probably lead to the sepsis, which leads to ARDS.
and she was an RT.
Yeah.
Every so often I forget about that. Um, cool beans. But yeah, I think the main ones you're really gonna have to know is your sepsis, anything that causes a lot of inflammation chronically, that near drowning or aspiration, any kind of lung injury, like a direct or indirect, um, be would be possible here. Um, Dealing with your stages now, you have three stages. You have the exudative, proliferative, and fibrotic. So your initial acute phase, which is also the exudative phase, you end up with a loss of surfactant, and then things kind of get crazy from there. This is days 1 through 7. So kind of that beginning point. Proliferative stage, inflammation kind of goes down. And there is attempts to fix what has been damaged. But that that reparation leads to granulation tissue formation and it kind of constricts and compromises your function. At least that's how I felt about it. This is days 7 through 14, so like kind of week 2. And then your fibrotic stage is when there's scar tissue. Oops. And then there's likely prolonged vent needed. I'm having such a hard time typing. Goodness gravy. So TLDR, inflammation, high permeability, loss of surfactant in the initial, um, proliferative, inflammation goes down, body fixes with granulation tissue. Oh no, no worries. I was thinking about it, but it could, like in a runaround way, it could make its way into art. So it could happen. Who's to say it won't? Oh, the pulmonary edema that comes from capillary leakage is technically not considered oncotic related. Oncotic is specifically albumin related. The rest of it leading to interstitial fluid shifts is still true. Some big words. Oh my gosh.
I don't think anybody asked, but I just like was looking it up while you were
Pop
talking.
off queen. Yeah, I was like, bro, I was like, I'm not very good with the really deep pathophysiology stuff on my end. So looking at that, it's like reading another language in my head right now. But yeah, proliferative inflammation goes down and you have granulation tissue, and it kind of constricts, and then your fibrotic is that scar tissue formation, so super, super constriction. Going into your diagnostics, you have an ABG. I know somebody mentioned earlier seeing respiratory alkalosis initially and the acidosis later,
Yeah.
not alter, later, there we go. Your respiratory alkalosis is, an attempt to compensate. So they're breathing really quickly, trying to get air in and out, trying to get that gas exchange going. So you'll see that respiratory alkalosis, but as it begins to fail, waste accumulates, then you end up with that respiratory acidosis. The chest x-ray, which will go down into the manifestations here in a second, refractory hypoxemia. So pretty much everything, all of your non-intubaty thingies for oxygenation are not working. You're going to always want to do EKG. They always want to rule out cardiac causes. Your swans, if they put it in, if they put in some kind of PA cath, they're going to be mainly looking at your wedge pressure. And then VQ mismatch, if that's done, will just show you that there's impaired gas exchange down at that level. So moving into manifestations, refractory hypoxemia, we talked about that already. So it's a PaO2 less than 60 with greater than 60, oh geez, greater than 60% FiO2. So it's that 60-60 rule or 50-50. Should probably put rule here too. Chest x-ray, I think it was Josh mentioned earlier, it's whiteout or ground glass appearance. I also like the idea of saying that it looks like the lungs have been hotboxed, because, I mean, come on, like, let's look at this picture. It kind of does. Like, you can't tell me it doesn't. Look at it. I think it does. That's great. Ooh, Diego asked a question. My question is, when you are taking the time to do an ABG when someone's having an acute asthma attack to see the initial respiratory alkalosis instead of
Well, it's
trying
not
to.
a question for them. I'm saying let me do it with the intonations. My question is, when are you taking the time to do an ABG when someone is having an acute asthma attack for you to actually see the alkalosis part? Yeah, it's like instead of trying to treat it first, in which case, if what you're trying to treat it doesn't work, they'll probably be acidotic at that point, right? Like I always thought it was funny.
Yeah, actually fair. I thought about it initially too. Like, Natalie, my lungs when I was 18. Oh no. Yeah, I think that sometimes it's like, are we really gonna do some of these in the emergent situation? Like, probably not, but if you did, like this is what it would show. So if this person does have a PA cath in or your Swan's guns, you're gonna be looking at your wedge pressure. So what pressure are you expecting to see? Are you expecting to see low, normal, high, crazy high, dead low? Everyone's saying high. Why y'all saying high?
So what's your PAWP representing?
We'll say at this point they're not on vent. Oh, somebody's making fries outside. I smell them. Yeah, so this one will be like a low to normal. I could see why you're saying vent high. That's a good question to ask. But yeah, so low to normal for just, this. I put that they're due to leaky capillaries as opposed to too much pressure causing the leak. I don't know. the patho words for that one, Diego. If you have patho words of wisdom for that, please go
Leaky
ahead.
capillaries, plus too much pressure causing leak. That's pretty much
I was
it.
like, I don't know a
What do you
bougie way
say?
of saying that. Forgive me.
How about that?
Brr, bougie. All right, that's better. That's super bougie. I love it. Okay. Going into your lung sounds, I know we talked a bit about, the possibility of it being into the interstitial, so being unable to hear anything. Oh wait, PAW high would be more of a cardiogenic pulmonary edema. Yeah. So your wedge pressure will be high if you have pulmonary edema from a cardiac cause. Um, but yeah, so lung sounds, I mean, if it's in that interstitial space, like it was mentioned earlier, you might not hear anything. Um, one random thing that I saw or rather heard, um, was like my preceptor was saying that sometimes with patients with pulmonary edema, it starts out as diminished sounds before progressing into another type of sound. So something just to kind of be aware of. So you can have crackles, rhonchi, diminished sounds in your ARDS, just depending on the severity, where all the fluid's at. Did you guys go over the PF ratio by any
No,
chance?
that's not something.
All right, never mind then. We're not gonna put that there. We put a lot of random stuff on here for like our extra information. So I was like, I don't remember if they talked about it, but let me ask.
No, it was
Um,
something that I think Nurse Sarah goes over. I
I
think,
love her.
and then I think we were just like, just in case it randomly comes up, now we know. But you don't gotta worry about that.
Yeah. And then leading into that VQ mismatch, again, we talked about that into the diagnostics, just showing that there's impaired gas exchange. For your interventions, I know Josh mentioned earlier placing them on a BiPAP or CPAP. I didn't really put too much on that here. That's a possibility. In this condition and in this specific condition, it's typically used as a bridge for intubation. So kind of seeing if they'll sustain or yeah, definitely less invasive before intubation. I mean, you don't really want these patients to crash out. If they're crashing out, like I'm not going to go to BiPAP, but if they're slowly progressing further and further, the nasal cannula, mask, non-rebreather, none of this are working, then going into BiPAP and CPAP and seeing if that's effective before going into sedating and intubating somebody. That would be nice. Please don't shove a tube down my throat without me, without trying something else first. Just a thought. Um, but yeah, so that's one of your interventions, as well as depending on whatever cause. I think Josh mentioned this earlier, is treating um, alongside the oxygenation failure and dealing with your oxygenation issue, dealing with that whatever the underlying cause is. So if there's infection, y'all know it's antibiotics. If you need to do any breathing treatments for it for whatever reason, so you nebulizer, anti, is this one word? Inflammatory? Ooh, it is anti-inflammatory meds because, as we knew, this was a condition that is a mass inflammatory response. So, providing some kind of anti-inflammatories to kind of help calm that response could help out. And then ultimately, intubation. Um, I don't even think I put a really big definition here. Oh, here it is. Definition. Let's see. There we go. So, your BiPAP. It's a non-invasive form of mechanical ventilation, mainly used for ventilatory failure. Um, I should probably put mainly here. Mainly used for ventilatory failure etiology. So it's a big old like sucky mask that they put around. Y'all seen the like the bag masks in your guys' BLS class. I kind of like to think of it as like that's the part that's around their nose and their mouth. And then it's really sealed on there. It's like really stuck to it. And they connect that via tubing to this machine to do their ventilation for them. But yeah, trying to get that mask on and off somebody, I was in like 212 and I don't remember for what reason, but I had to get the mask off somebody and I was like, oh, I don't know how to do this. It was weird. But yeah, I already mentioned the etiology that it's used for. Here we go. Okay. So intubations, indication. So this could be either for ventilatory or oxygenation failure. It doesn't really matter. Just if somebody can't breathe one way or the other, oxygen's not getting in or out, you're probably going to be intubating. So it could be used for either type of respiratory failure. But there are some more indications for it. We talked a bit about 50-50 or 60-60 rule. That's kind of going in line with your refractory hypoxemia. But what other indications could you have for intubation? I mean, other than like, your ARDS that we're talking about. Yeah, if there's some kind of altered mental status, like how we mentioned that drug overdose. Oops, that's not correct. Drug overdose or some kind of head injury leading into vent failure, some kind of obstruction. Yeah, or anticipated obstruction. So facial burns, that's not how you spell facial. Facial burns, some kind of face trauma as well. That's not how you spell trauma. One of these days I'll get better at this. I know I will. Just eventually. Um, let's see. Oh, I just realized another one. Anaphylaxis. Getting ahead on week 7 content.
with the burns.
Oh, I was like, what you talking about? I forgot that was week 7 for them. When they can't clear secretions to keep the airway open. So yeah,
Or six, I can't remember. 6 or 7.
your guess is better than mine at this point. Um, but yeah, those are, I feel like those are your main ones. So anything that's you can think of for ventilatory or oxygenation failure, or if you are anticipating one of those failures occurring. So like you have a facial burn. Okay, we see the singed nose hair, we see the soot. We know that there's going to be an extreme amount of swelling, and we need to make sure that we maintain their airway before it even goes to shut down. So that would be an example of your anticipated obstruction or anaphylaxis um, if we're for whatever reason not going to be able to control the inflammatory response and their airways begins closing up. We need to shove a tube in there before it goes completely gone, or else we are doing a trach. And that's not good. Crikey. Let's see, is there anything else here? No. Okay. So you do have some responsibilities before intubation and after intubation. So before intubation, what should you look at? What should you do? Anything. Yeah, hyperoxygenate to the best of your ability is definitely one. So you're gonna do that via like connecting an ambu bag. Um, that'll be one breath, Q 5 to 6 seconds. So like 10, oops. Yeah, 10 to 12 breaths a minute. Always, yes, always. That's not how you spell always, gosh darn it. Have bag valve mask. Yeah. So whenever you have a really critical patient, you're gonna have a lot of your resuscitation stuff. It should be at bedside already. We ain't gonna play around with this. No, thank you. Where is the endotracheal tube located? Not in the person, but like on the floor. So it's in the kit in the crash cart. So, making sure that you have the crash cart, go and get that. They'll have that little, I don't I don't know the name of the metal thing that they put in to like visualize the airway. You put it together and there's like a little light on it so that they could visualize the
Ooh,
That's a bougie word, Ryan. Thank you. Yes,
laryngoscope.
laryngoscope. Ah, X-ray for placement. That's definitely going to be after. We're going to want that x-ray, making sure that they are in the right place. Let's see. What other MD on Monday used a bronchoscope? What kind of stuff did you see on Monday? You saw some stuff on Monday? Oh, and you saw an extubation. Cool. We'll talk about this later. I'm interested. Um, restraints, sedation. Yes. Restraints, sedation, IV access, always good things. For your restraints, you're doing your soft wrist restraints. Nope, that's not how you spell wrist. Restraints. Because I don't know about y'all, but I think if I'm still kind of mentally there and I'm struggling to breathe and you're trying to shove something down my throat, I'm probably going to try to pull it out. So it's just there to make sure they don't pull out. Oops, they don't pull the tube out. There we go. So sedation and a paralytic as well. Paralytic. Always sedate before you paralyze. Please, please don't shove a tube down my throat while I'm still conscious. And make sure that I'm not consciously aware that I am paralyzed. That will just cause you to freak out more. Um, there's a oh, this is gonna be bad. So there's a certain you won't really yeah, Diego, you already know what I'm gonna put down.
Yeah,
Yeah. So sometimes you could use etomidate and oh god, succinylcholine.
succinylcholine.
Thank you. Big words. So etomidate is your sedative. I forget they also use I just know it as rock, but I don't remember the actual name of the medication. Um, but if you do see these, I think it is quite funny, and I think it is a great way to remember that you need to get a sedative before a paralytic. So just remember this phrase that I don't want to get canceled for. So let's just highlight that.
Yeah, always date before you suck.
Why do you want to be canceled? Why do you want to be
I
canceled?
remember this coming up for actually for the cap, maybe like the Kaplan
Oh wait.
or yeah,
I did. I remember. I know exactly what you're talking
yeah,
about. Good times. Let's see. In terms of other equipment that you'll need at bedside, making sure you have suction set up because you need to suction airway before they go to intubate. We're going to be positioning. What the heck? Oh, okay. I just got an email. It's from Chase, but it made my phone just go kind of crazy, and I was like, "Oh, what's that?" Positioning the patient in a position that makes them available to actually do the intubation. So you're placing them completely flat and at hip level, taking the headboard off. I did not, probably should have known that that's something you could do. I just didn't really think about it, but you could just like the back side of that off. And the doctor's going to stand basically behind it, looking down at their head to be able to do the intubation. That's definitely going to be after. Head of bed will want to be up. Yes. Let's see. Where was I at? Okay. MD behind bed to intubate. There we go. What else am I missing? Am I missing anything else? Sedation, soft restraints. Oh, how long should an intubation attempt be? Yeah, 30 seconds is the recommended. If you go over that, this is just more time with them not receiving any oxygen. And then after they've been intubated, I guess this should be an after part. Taping to secure the lip line, and then looking at that measurement. That'll be something you'll have to continuously reassess to make sure that tube's not moving in or out of place. Getting an end CO2 detector, not CO3, detector. Oh God, ET, CO. God, these are big things. Um, yeah, so that's making sure that the ET tube is properly placed. You should have CO2 coming through. You should have CO2 coming through that. If you don't, probably not in the right place. So looking for bilateral chest rise. What if you only got it into one lung? That would be fun. That'd be a story. You're gonna have to probably take it a little bit back out. And it does happen. Let's see, and verify, no, verify measurement here. Da, da, da. Chest X-ray, gold standard. Kind of like and I feel like any of the tubes pretty much is chest X-ray is a gold standard. Let's see, should be on right bronchial, right?
Yeah, so if it were to go into like a lung specifically, it'd probably go into the right side. It's a little bit wider than the left side. The left side's constricted by the heart.
Why do you know this? Why do you know this?
I don't know.
Pop off, I guess. Interesting. I read it. Okay, love that. Okay, I don't read, so good for you. You're learning more than I did. And then in terms of your of the cuff that's inside, so that needs to be inflated. So how many, oh God, millimeters of mercury, I think is the measurement here. Are you inflating the pilot balloon to inflate the cuff? I think this was part of one of the readings. I think that's why I put it in the notes. I think I was salty about it because I got the question wrong. Yeah, so that 3 cc of air is correct. Oh no, 3 cc of air. So that's the syringe, but there should be a certain pressure to be maintained inside of the patient's throat for the cuff. It's okay. I'll just put it in. So it's going to be 15 to 20 millimeters of mercury. Millimeters of mercury? I'm pretty sure that's what that is. Always forget. HG, don't know
Yeah,
her.
mercury.
Okay, so making sure that the cuff is properly inflated and stabilized. So they shouldn't be able to make any sounds or to talk, and if they can, then something ain't right, and you should probably fix that. We talked about our soft wrist restraints, making sure those are on properly. Why would you need an NG tube after? Yeah, so decompress. Yeah, so you want to make sure that they don't aspirate, decompress. He doesn't like when I abbreviate stuff. Sorry.
You can abbreviate, you just have to have what it is written out first.
Hey, sorry. Okay, we talked about that mild sedation. Preferably, you would sedate me before you stick a tube down my throat, but maybe that's just me. I don't know. Just a thought. I would appreciate it. But if you didn't have time to do that, sedate me after, please, and keep sedation running. Let's see. And then after everything is said and done, so you're connecting everything up to the machines, making sure that there's no twists or turns or kinks in any of the tubing, and then setting up the ventilator mode. Yeah, that's a lot of stuff there. There's a lot that goes into intubation with its what you need to do prior, because it's all gonna go down pretty quick. And then afterwards, there's a lot of stuff that you need to do. That chest X-ray, the CO2, NCO2 detector, measuring that lip line, making sure the chest rise is equal, reassessing, probably a good one. I was like, I know I'm missing something. Reassess vitals after placement. I like that idea. Placing head of bed up as well. And then in terms of the cuff, inflating it so that it's at 15 to 20 millimeters of mercury to make sure that it's not able to really move around. Soft wrist restraints and doing your checks with that. So that's your CMS Q2. Making sure that there's no skin breakdown as well, because I'm assuming this patient's in the ICU at this point. And there's a very really big risk of skin breakdown with these patients. NG tube in. I got to do that. That sedation continuing on and Um, titrating your sedation based off of your RAS goal. So knowing you need to know your RAS goal uh, before you go and try to titrate stuff, and you need to be reassessing that score frequently to make sure you're in the right range. Is there anything else I'm missing, Diego?
No, I think you covered everything.
Okay, I feel like I'm having such a hard time trying to like type and talk that I'm losing my train of thought because I'm trying to type. This is bad. I don't have the skill. Sorry, I wasn't a gamer growing up. Sorry. God help me. I don't think do you remember if they really have to know the types? Pressure
Mm,
timed? I don't think so.
you should know the main ones for sure.
Modes though.
Oh, modes, types. Like, what do you mean types?
Pressure cycle timed or volume. They don't really have to
No,
know that.
not at all.
I realized after I put it, I was like, that's not applicable right now. Okay, so you have different types of modes or like preset stuff. We need to know
Yeah,
ACP,
exactly.
DMV, yeah.
Yeah, that
So
you do. Yeah, the types you don't have to like the yeah, you don't have to know that other stuff.
yeah, so how do you determine what mode a patient should be on? Peep. I love peeps. Definitely ARDS may need more for PEEP, but that's definitely a very specific setting that they might have. Yeah, so we're gonna basically just look at their overall status, like what's their condition, what's the goals, how screwed are they, how much are they not able to breathe. So if they're not able to breathe well, they're gonna need more help. If they're able to breathe kind of well, that's help. Yeah, so overall patient presentation and goals. Barrow lung. That's definitely the barrow barotrauma is related to PEEP, and we'll go over that in a moment. In terms of modes, though, you have like your little preset ones. So you have your controlled mechanical, oh God, ventilation, AC, which is your assist control. Oh God. SimV, which is your oh God, synchrona, and he's just watching me struggle. This man is watching me struggle. Intermittent mandatory ventilation. Gosh, help me. Okay. And then CPAP, spontaneous. They weren't too crazy on this one. So in terms of your controlled mechanical ventilation, also known as CMV, what kind of patient is this one good for? Oh, I cracked my jaw. Yeah, so no respiratory drive. So they're going to need a lot of help. This could be a first setting after intubation, but again, it really just depends on what is going on with your patient. So they can use that or AC as well, which we'll get into that in a moment. In terms of your CMV, you have gas at a preset rate, tidal volume, and pressure, with no regards to their breathing effort. So if they manage to take a breath, cool, the machine doesn't care. I just realized this says TV. I didn't write tidal volume. Sorry. There we go. What is going on here? Okay. Um, okay, moving into AC. Um, let's see. We kind of meant, or I kind of mentioned that this could be another good setting after intubation. What kind of patient is this good for? Anybody? I'll give a hint. It's a step down from CMB. Yeah, so they're pretty weak. So they can't take any regular. Definitely, this is another good option for someone who's been intubated. I think they really would try to go more with assist control because it makes it so you're starting off at like a lower acuity setting. Like this is like absolutely screwed. Like this patient can't breathe at all. This one is like they can kind of breathe, but we're really helping out. Important thing to note with this is it is supporting every breath. That's not how you spell breath. There we go. Um, so if they manage to take like a really weak breath, it's giving that extra support. Hence assist control. It's assisting. I like it, Picasso. All right, so SimV, what kind of patient is this good for? Yeah, so this is good for someone who's weaning, or ready to wean. Ow, here we go. So this one allows for spontaneous breath efforts and it synchronizes, hence synchronized intermittent, mandatory, blah, blah, blah. Synchronizes to the patient's respiratory effort. So it kind of detects it and it's like, oh, okay, let's kind of back off or let's help more. And then this one, honestly, I don't really think they talk too much about this one. So we'll just put this in. So augmenting breathing. Basically they can breathe on their own, but it's just a slight augmentation, pretty much bottom of mechanical ventilation. Moving into your tidal volume, what is a normal amount to give in terms of milliliter per kilo? 6 to 8 that's on milliliter per kilogram. And this is basically the volume of air received by the patient with each breath. Per breath, yeah. And this is depending on whatever your goal of treatment is. You typically want to start lower so that you don't cause any injury. And then if you have too much for too long, you can end up causing, again, like that barotrauma. Terrible with this typing talking thing. Diego, this is your job. This is your job. Okay, I'm just messing. Respiratory rate. I hope we know it. Girl, you will always working. Please take some time off. Take some time to care for yourself. I worry about you. You work so hard. I hope you don't have to work so hard in the future. Respiratory rate. I hope we all know what a regular respiratory rate is. What's a regular respiratory rate? But you're always working though. So in my head, that's working hard because it's still taking a lot of time out of your day. Like that's how I see it,
Well,
you know?
he's multitasking, so it seems like he's working smart.
It's working, it's definitely working smart, but it's still another strain. Like I think it's still like a mental strain. That's how I see it though. But get your bag. Okay. But yeah, so we have a goal rate of 12 to 20. Please know your regular respiratory rate. And this one is dependent. Is that how you spell that? Yes. On CO2. Nope. CO2. There we go. Yay. So you're going to be looking at the PaCO2, and then if the CO2 is high, you're going to be overventilating. So basically, if they're acidotic, we want to turn them more basic and have them breathe a bit more, hyperventilate them. And then if their CO2 is low, then we want to lower the respiratory rate to hypoventilate. Is that how you spell that? Yes. No. Nope. I'm just gonna divide it into words. Hypoventilate. There we go. Yeah. Yeah. Let's see where we at. Also important to note that as you're beginning to wean and the settings or your modes are changing, so as you're moving from AC into SimV, the respiratory rate will come down. So, you might start with if they're on a full assist like that CMV, then they might be up at like, let's just say 18 or 20 respiratory rate. Um, but as they go into SimV, they might change that down to like 8 or 10 as the patient's able to breathe more on their own, and then you just have the ventilator coming in every so often to assist. But yeah, just something to note for that one. Your fraction of inspired oxygen, also known as your FiO2. What is the normal value of room air? 21. Oh, girl, you're fast with that. Gosh darn. Um, let's see. Yeah. So after intubation, I'm so bad at typing this. After intubation, it's not abnormal to have them on 100% FiO2. Um, and with an overall goal is to maintain kind of like our rule, that 50-50 or 60-60 rule exactly. PaO2 greater than 60 and a SatO2 greater than 90%. Um, one thing to watch out for, and I mean, this goes for every kind of form of treatment we have, right? Yes, girl, that's exactly, you're reading my mind. I'm getting kind of scared. I'm kind of afraid. But yeah, so with any treatment, we can swing too far the opposite way, right? We could be giving too much oxygen and then we have oxygen toxicity. Yay. Somebody asked me about that from second semester, and I was like, oh my God, I didn't even question that until I was in like fourth semester. Ah, but yeah. Um, does anyone know any of the signs? Did you guys go over signs and symptoms of oxygen toxicity? I have it in my notes, but I don't remember if it was something that I looked up on my own or not. I probably looked it up on my own. Ironically, it's kind of the same as like if they were oxygen deficient. It's kind of like the same stuff. Um, just kind of confusing. But dyspnea, restlessness, fatigue, respiratory difficulty. They'll look like they're struggling oxygenation wise, and then you look at it and it's like, oh, it's 100%. That's kind of odd. But yeah, so that's something you want to try to avoid. So that's why it's so important to make sure that you're titrating your FiO2 to make sure that you're just pretty much maintaining that oxygen greater than 90%, not overshooting too far. So you don't want to end up in this territory. Now you got the opposite problem. Moving into PEEP, I know Josh was talking about this a bit earlier. This is positive end expiratory pressure. Typical, I think it's 2 to 5. Oop, 2 to 5. Where did I get 2 to 5 from? Oh, I've got all these different values up here. Lord help me. Okay. So I have on my notes, and Diego, correct me if I'm wrong, 2 to 5 cmHT or HT, God help me. H2O, that's on O, there we go, that's an O. With an average of 5. But you could have a cap
Of 10,
um
yeah.
of
Or
15
15? That sounds about right,
or
yeah.
20. It depends. It depends on the patient's situation. And in instances like this, now we're considering like, for example, like the ARDS, they might have a higher PEEP initially. They might be up at that 15 or 20, just to keep the lungs open. So the point of this one is basically just that. So keeps air in lungs at the end of expiration so that the alveoli don't completely collapse down into itself. Um, like I was saying, it's good for ARDS. Oops, good for ARDS. Um, I think Brooks Byers says, doesn't it need to be at least 5 to open alveoli? Diego, I didn't look at Brooks' PowerPoint. I'm gonna
What'd you
be
say?
real with you. Brooks' PowerPoint says 5 to 10. Could you open her PowerPoint?
Her PowerPoint, I believe, does say that. Unless you're thinking of pressure support. Pressure support is 5 to 10.
Oh, okay, cool. Cool, cool, cool. I was like, I'm not sure because I think when I did my notes, I only looked at Rydell's, so I was like, I don't know what's here and what's not on hers.
Yeah, so pressure support is literally pressure during inspiration. PEEP, the word expiratory is in there. So this is pressure applied after exhalation to keep it open. And then PEEP is alveoli open during inspiration.
Yeah. And because we're dealing with all this pressure, you have that risk of barotrauma, a pneumothorax, or something called subcutaneous emphysema. Does anyone know what that is? It's kind of trippy, high key. There are too many numbers to know. It's horrible. Yeah, so subcutaneous emphysema basically means that your air, like the air from the lungs, is getting trapped underneath the skin. Um, So when you push down on the skin, like kind of where the ribs are, it will quite literally feel like Rice Krispies, like snap, crackle, pop Rice Krispies. It's kind of weird, kind of trippy. Look it up in your spare time if you want to be grossed out. It's definitely yum. Y'all want a bowl of cereal now? Mm-mm-mm. But yeah, so subcutaneous emphysema, that's what she's referring to with that. It's basically air has gone and displaced itself to be underneath of the tissue. Um, So that's a problem in and of itself. Not very comfortable. And then the last thing we have is that pressure support. So that is keeping the alveoli open during inspiration. Okay, during inspiration. There we go. And then this was based on patient weight. This can be seen when weaning. They don't really go too deep into this. I just realized I never put the value in, 5 to 10. There we go. That's important. Oh gosh, so many responsibilities. Lord help. Okay, so we talked a bit about responsibilities relating to intubation, pre and post intubation, and then now dealing with the ventilator. So we just talked about a whole bunch of different modes and settings. So you're gonna have to know all of this, unfortunately. So know the mode and settings at beginning of shift, knowing your goals of care. Um, you know, if the patient's being determined, oh, okay, like we might try a weaning trial, spontaneous breathing trial, whatever the case might be, or they've been maintaining pretty well on AC, let's move them to SimV, or whatever the case might be. So knowing where you're going with this, is there going to be changes to your plan of care? Is it going to be consistent? What are they doing? So knowing your mode settings, da da da. Moving into sedation, I talked about a rascal. So this is a really important part of this. I don't think you guys have to know the scale particularly. Diego, correct me if I'm wrong. It's a good thing to have in mind. So you have like that positive numbers, 0, and then your negative numbers. Your negative numbers basically is going into sedation. Your positive numbers are going into more awake or agitated. So typically, you don't want somebody who is on a ventilator on sedation to be agitated. So typically, your RAS goal will be like 0, -1, or -2, it just kind of depends. Probably 0 and -1 though. And yeah, that's why they're on restraints. And yes, your order will say it. So it'll say like titrate sedation or whatever med it is, to maintain a RAS goal of blank. And so you'll titrate based off of the order. And for titration, because I know you guys haven't talked too much about titration, it'll say in the orders too how much you can titrate and for what reasons you titrate. So for some it'll be like every this is just blurbing numbers. Every 5 minutes, you can titrate this random med, 2 micrograms per kilogram per minute. If the heart rate is whatever, if the heart rate's down, if the heart rate's high. So it'll tell you in the orders how much you're going to titrate and for like what reasons you're going to titrate. So it's not just going to be like, I'm taking a guess. I think one's a good number to go up now. No, nar. Um, Along with your sedation, you have sedation vacations. Love that for her. Um, so it's basically just taking them slightly out of sedation, not all the way up. I don't want them to be, you know, agitated, swinging at me. And this is going to be daily. I wish I could go on a daily vacation. That sounds nice. But, it is what it is. Um, so you're going to be doing a sedation vacation daily, just to kind of make sure that they aren't going too deep into this. They're typically not on any kind of paralytics. They're just on the sedation. And then if they're on sedation for a prolonged period of time, your vital signs can be affected. So vital signs every 15 minutes, because your heart rate and BP can be lowered due to it. I mean, it makes sense. If I'm sedating something, it's causing everything to go down. Safety, we talked about our restraints, our CMS and skin integrity with that. Do 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 do. Where am I at? I wrote this out kind of weird. Sorry. I'm trying to like correlate it to where it's at on the notes that I have on the side. I'm like, ooh, I don't remember where I put this in at. I'm assuming I meant to put ventilator assessments. So if I'm dealing with a ventilator, what should I be assessing on the ventilator? Just basic stuff. Anything. Alarms. I love it. So we have high or low alarms. I think, yeah, we'll go into that in the section further down. I have another section specifically for alarms. What else? No condensation in the circuit. But yeah, looking at high or low pressures for your alarms, and those all have different meanings too. In terms of the condensation in the circuit, please don't. Never lift circuit and dump water into patient airway. I mean, I felt like that was kind of self-explanatory, but I love the fact that it's in my notes. It's kind of funny. Yeah, always checking your mode and settings on your ventilator. Let's see. Making sure, I don't know, just a thought, maybe it's plugged in. I always thought that part was funny too. I was like, because you know what, it's possible. And something I found out, which I didn't even consider, if I'm being honest with y'all, when when something's plugged in, make sure that it's plugged into one of the red outlets on the wall or wherever it's at. Um, because the red outlet specifically, if there's a power outage, it'll run on backup generators. Yeah, I was like, I hadn't even thought about it until I looked at it one day. I was like, why are these red? Into red outlets. Just a thought. Don't make your life harder than it has to be. Don't have your pump randomly die on you because you didn't. Who was in Houston? Dang. I feel like I learned like everyone's life story. Oh, I hope you got paid well. That's all I'm gonna say. I hope you got paid well. I'm so sorry. It was definitely fun. Yeah, okay. 40 hours overtime each pay period. I remember like I wasn't in like a hospital, but like for care homes, I remember there was one point where this was messed up, high key. They would move patients that had COVID or suspected COVID into a separate facility from the one I was at. Um, so they moved them like 25 miles inland, because then they wouldn't have to report that that facility that I was at had active COVID cases. So they would send some of us to the other facility for overtime. So I was doing a lot of overtime in that way too. There's a lot of weird stuff going on during COVID times. That's all I know. Is there anything else I need for this? We only have 4 nurses that had to work day shift and night shift. You just lived there at that point. You might as well just sleep in one of the in one of the beds off to the side. I'm so sorry. We basically did. I had to do that. I slept in like one of the rooms at one point or another. I was there for 2 days at one point. I probably shouldn't have been, but here we are. It is what it is. Okay, no condensation in circuit. Yeah, empty out as well, and don't put towards patient, essentially. I think I don't think there's anything else that I want to really put here for ventilator. We already talked about post-intubation lung sounds, chest rise, ET2 positioning, lip line as well, pneumothorax, suction. Mm, I think the only other things is skin and GI, which go into your VAP bundle pretty much. So what is your VAP bundle? You're gonna have to know this, unfortunately, or fortunately. Oh, actually, that's a good one. Yeah, that's something that I forgot about. Yes. So moving the tube often to prevent mouth pressure injury. I saw it one time. It was kind of gross. So they'll move it from like the left side to the right side, and then you obviously we're moving it, so reassess and make sure that it hasn't moved further out. The number's still the same at the lip line. It's Q8. You're probably right. I'm sure you are. I don't recall ever seeing like an order for it, so that's why I was like, I'm honestly unsure of the time frame for it, but Q8 wouldn't surprise me. Let's see, da, 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 sedation, blah, 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 position, skin. I mean, anyone in ICU, you're doing skin. GI, which goes into, yeah, that seems to be it. Okay, so just a VAP bundle. So what parts of your VAP bundle? What's part of your VAP bundle? Ventilator associated pneumonia. Oral care Q 2 hours. Head a bed up to at least, I think they said 35, but 30 is close enough. Suction PRN. I'm still salty about that. I will emphasize that forever because I always thought it was like suction every 2 just because of how it was written. Um, but up to 2 Q 2 hour if needed. Oops. There we go. GI prophylaxis and DVT prophylaxis and sedation, vacations daily. Yeah, so for GI prophylactic, what meds are you giving? Protonics. Protonics. Well, basically your PPIs and H2 blockers. Oh yeah, Protonics is one you'll see a lot. I think that's it for VAP bundle. It's pretty straight up, but you just have to know those numbers. Ooh, I should get moving along. I just realized we've been here for like almost 2 hours. All right, we'll get through this lickety split. We just have discontinuation. Yeah, just discontinuation, and then I have some stuff on sedation, but it's just extra info. Oh, and alarms. Psst, forgot about the alarms. Okay, so moving on to alarms. Sorry, Diego, I'm all over the place. I'm sorry.
It's okay.
Um, what are you checking first when you hear an alarm go off? Check your patient first. Check check your patient. Please. Donnie, you came back. I saw you got kicked out at one point. I was like, oh man, I saw you trying to come back in. But yeah, check your patient first. I feel like I see it so often where something goes off and the first thing people look at is whatever's beeping. And I'm sure that's fine. You can look at that. But it's like if your patient's sitting there dead and you're looking at the machine trying to figure out what's wrong with the machine, your patient's sitting there dead. Like I can fix the machine, but that's not gonna fix my patient. Sorry. As horrible as that sounds. In any case, moving into high pressure and low pressure alarms. So what are some causes for a high pressure alarm? Some kind of obstruction, right? That's like the general Couch? I'm assuming yeah, I was like, I'm assuming you meant cough. Some kind of obstruction, so coughing can be one. Biting on the tube. Tell them stop. Tell them to stop that. What else can cause obstruction? Yeah, secretions. Ooh. And then the last one is that yeah, collection of water in the circuit. So if a patient is coughing, what do you do for that? Ooh, there's a gnat in front of my face. Is there anything you could do if the patient's coughing? Yeah, the vent resets itself. So not applicable, vent will reset after a few breaths. And yeah, definitely assess your patient after. Imagine it's like, oh, okay, they were just coughing, and then like they stop coughing and you walk out the room and it turns out the whole time they were like it was secretions blocking the entire time and the machine's still beeping. Like, ooh. But yeah, assessing your patient before, after, during the whole bit. And then if they're biting on the tube or fighting it, what are some things you could do for that? Block. Yeah, some kind of bite block. Um, what else can you do? Bite block is a good one. Tell them no. Reposition the tube. Yeah, and readjust. Calm them down. Tell them no. I mean, essentially, like as horrible as that sounds, communicate with them and tell them, hey, like this tube is gonna help you. Don't fight it. Don't bite it. Um, Now, if that doesn't work, what are you gonna do? Oh, Ghostbusters. Yeah, so you might want, that's okay. You might want to consider increasing your sedation, and one of those is propofol. Should probably write out the whole word. Sorry, Diego, I'm doing my shortened words again. Yes, increasing sedation. One of the main ones you'll see is propofol. So that's a good one to know if you're gonna chill in the ICU for a minute. If you're coming up on one of the weeks that you're gonna be going, know that med. It'll come up a lot. Da, da, da. Ooh, I just realized we missed a really big one for a high pressure alarm. What's the worst cause of your high pressure alarm? That pneumothorax. I scrolled down a bit and I was like, ooh, forgot to put that down there. Yeah, your pneumothorax. My bad. In terms of secretions, we know how to deal with secretions. So that's your sectioning. Pretty straight up. If there's too much water in the circuit, get rid of the water. Drain the water. But please don't dump into patient airway. I mean, I feel like that's self-explanatory, but you never know. I don't know. Just my thoughts personally, but who knows? And then that worst case, your pneumothorax. So knowing your signs and symptoms of that. So what are signs and symptoms of your pneumo? Yeah, so diminished lung sounds, breath, absent sounds on affected side, unequal chest rise, chest pain. Yeah, a whole bunch of stuff. So at this point, not much you could do. You need a chest tube. And then at the end of the day, for both of these, I'll put it down here. If you cannot, dang it, determine the cause of alarm, what do you do? Ouch. Yeah, you're gonna need to bag them. Bag them. Bag them. Cool, 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 cool. All right, so what are your reasons for a low pressure alarm? Yeah, most common is some kind of leak, or some kind of a poor connection or complete disconnect. So some kind of leak or disconnect. So sometimes you can hear the leak. I don't need to know that. Trying to think if there's any other part. I mean, it's pretty straight up, right? So for both of these, I mean, you're gonna want to follow all your lines to make sure no disconnection or determine where a leak is. Oops. And then the worst one of this all is that, yeah, oops, internal machine error. So AKA machine done decided to get up and leave, and said, I'm out skis. And that one's super bad. That one is, yeah, we're gonna have to bag them while we wait for a new machine to come in, please. But yeah, the low pressure is pretty straight up. If there's not a, yeah, I call for help, call for help, probably call for help. I mean, just a thought. Let's see. Da, da, da. Okay, yeah, I have this whole section here. Okay, on to discontinuation. When do you consider weaning a patient off of your ventilator? There's multiple reasons for it, or multiple criteria to determine that. I think that's going into, okay, yeah, that's going into your what's it called? Diego, what's the word I'm looking for?
What?
Oh, that's going into your spontaneous breathing trial. So that ABG and respiratory rate, that's going into your spontaneous breathing trial. So we'll talk about that one down here in a second. But to just consider, yeah, you do have to do it. But I think I was just referring to like general reasons. So you consider weaning the patient when you don't need the ventilator anymore. So your reason for your ventilator no longer exists. Patient is hemodynamically stable. Like just very like basic things in the beginning, right? Um, and then while weaning, you're going to change to SimV. So we talked about that being a good in between, and then possibly adding pressure support. I'll put optional because it might be there, it might not be. And then looking for all your good signs. So making sure that you're where am I at? There we go. Jeez, help me. SpO2 is greater than 90, blood pressure is less than 160/90, heart rate less than 110, respiratory less than 28, and good respiratory efforts. Um, looking for signs of the intolerance. So pretty much if those numbers up there are out of range, or you see these, so decreased level of consciousness, fatigue, pain, or change of like conscious, they're super stupor, then they're not tolerating that well. Now we're going into spontaneous breathing trial. So there's a couple ways to tell that it's successful. First and foremost, when you're going to do your spontaneous breathing trial, you're going to be taking away the mechanical ventilator support, but you're keeping the tube in place. Because I don't want to go through the trouble in case, in case for some reason they don't tolerate it well, um, and like, and they start crashing. At least the tube's still in place. I could just hook the machine back up, right? Like, don't make it harder for yourself, please. Um, so you try to encourage them to breathe on their own. And then that's when we get into the ABG in 30 to 60 minutes has good results and making sure they're hemodynamically stable as well. So let me just go like this. I feel like this is easier if I just go like this. Yay. Cool, 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 cool. So then if all of these are good, they pass their spontaneous breathing trial. Now we go into extubation. So prior to extubation, there is quite a few things that we have to do. What are some of those things that you would have to do? I mean, other than the stuff we already talked about with spontaneous breathing trial and whatnot, but like we're about to actively extubate. Yeah, I think that's a good one. So allow for brass to, well, I don't want to say increase. Well, yeah, I'll just say sedation wear off because I want them to be fully there so that they're able to breathe for themselves. I don't want them to be, conked out, half awake, half asleep, because they're not going to be able to breathe very well. Hyperoxygenate the patient. What else we got? Yeah, rapidly deflate the ET cuff. Move at peak inspiration. Oh, that's not how you spell that. Inspiration. Yep, instruct patient to cough, because we're dealing with a whole bunch of secretions. And then that's going over here, monitoring patient every 5 minutes, making sure that they're not decompensating as well. A couple more things for prior to extubation, alongside of this, head of bed up. You're also going to want to suction. So the both of these combine is just because they have a lot of secretions present there. Da, da, da. Did I put cough already? Okay. No, I did not. Okay, cool. So that seems to be all for beforehand. So after extubation, monitoring the patient frequently. If they need oxygen, give it. You probably will put them on something. So maybe like the nasal cannula after should be fine, just so that they transition back into room air. I mean, if they get to that eventually, that'd be nice. Same day, that'd be cool. What is your medical emergency that can happen? Well, I guess other than needing to be reintubated, but yeah, Strider. So that'll be your sign of a medical emergency. Ryan, what the heck? God, you said so much stuff. That's crazy. Girl, you're telling me the story on this afterwards. That's all I'm saying. I gotta know. I need to know. Bet. Okay. So yeah, your starter means there's basically a whole bunch of edema down in the throat. So laryngeal edema, throat swelling. Um, so the goal of this, you need to be able to reintubate ASAP. That is not how you spell reintubate, apparently. Is that not? Mm, I'll just divide it into two words. Reintubate ASAP because if too much swelling, then you're gonna have to trach. So that I don't know about y'all. I would not want to be trach. Please put the tube back in my throat ASAP. Um, let's see. And then calling your rapid response team because you're gonna need more hands there. Pulmonary rehab. There we go. ISTCDB, early ambulation if possible, your oral care, hydration, sure. And then education. Obviously, they just had a tube down their throat for a fat second. Their throat's gonna hurt. So one thing you could tell them to deal with that pain is maybe some cough drops or lozenges for pain. And I think that is it for this. The next part I have on sedation is purely just, I just realized I put insert picture here and then I never did. Let me get a picture of that real quick. It's just for your own purposes. I don't recall how much that you need to know about this, in terms of what meds, your RAS, but I will put it down here. I got a picture, Diego. I see your thing right there.
Yeah, let's see if you have a
Oh
quality
my
picture.
God. Why do you hate on me so much? Can you hear this man? Y'all heard him?
Okay.
There we go. Yeah, so I think this is good. So that's what I was talking about with the positive and negative. So positive means they're more agitated, restless, the whole bit. Negative is sedation. You definitely don't want to go into five, -5. They're basically completely not there. And then your RAS score, you're documenting every hour. Your probe is very quickly to onset. It's in a glass bottle, so when you spike and prime it, there's this little like, depending on what facility you're at, but at least at PIH, I think all of them are pretty much the same ideology. But kind of where the drip chamber is, there's this little like circle that you can like what's the word I'm looking for? I wanted to say unclamp, and that's not the word, or unbutton. I was like, no, that's not the word either. Um, but it basically opens up like a part of it so air is able to go in so that it's not gonna like pressurize weird. It makes it so that it's still able to draw. So that's an extra step you have to take when you spike and prime a glass bottle. Um, so it's gonna start typically at 5 mics per kilo per minute, and then titrate. This is what I was saying, kind of like you'll have something like this. So titrate by 5 mics every 5 minutes as needed until you achieve a score of whatever RAS that you needed, and then your max will be 70 mics. Um, yeah, that's the part I didn't know how to do on iHuman. I was like, "What are they asking me?" Because I didn't do the notes for it yet. And I was like, "I don't know what's going on." Probably should have done the notes on this first. My bad. Um, but yeah, with this, like we were talking about earlier, your probe can cause a decrease in your heart rate and your blood pressure. So watching out for hypotension and then frequent tubing changes. Why did I put that? Oh, the tubing itself. I was like, tubing. Okay. It's lipid based. Ew. Ew. Yeah, I remember that. It literally looks like milk going through the tube. Kind of gross looking, high key. Um, moving into Versed, don't really need to know too much. It's the same kind of dosing ideology, starting at a certain amount, titrate it by a certain amount until you achieve a score that you desire. Um, and just because of the type of med this is, you can give flumazenil or romazicon if there is overdose, over sedation. Fentanyl, we love fentanyl. You titrating by 25 mics, Q 30 minutes until you reach the RAS score that's ordered. We have a max of 100. Narcan if overdose, because this is super super drug. Um, yeah, super strong. Yeah, we love fentanyl. Great. But this one is nice because it keeps them more stable. But it definitely scary. Scary meant to deal with. But yeah, I took a lot of time to do the outline, so that is all on my end. I will stop talking, and Diego, it's up to you to do questions.
Okay. I have 10 questions for you guys. So I tried to make them harder than, I don't know,
Bruh,
because we only have
bruh.
10. So hopefully it's actually a decent challenge. All right.
I did some of them. I was like, oh,
All right. Number one, which of the following patients would you prioritize first? A 71-year-old male with pneumonia, SATO2 of 91%, respirations of 26, temperature of 102, 97 over 54, blood pressure, warm diaphoretic skin. B, 17-year-old female with a DVT who is having cold sweats and is complaining of shortness of breath. C, a 6-year-old male with an inflamed epiglottis whose wheezing stopped. Or D, an 85-year-old female with COPD on a nasal cannula at 2 liters per minute who suddenly became agitated. Wait for a few more and then we'll just kind of go over it a little bit.
what would I do right now? Oh, he changing his answer. The boy got obstruction.
So let's talk about what could be happening in each of them. So what
Ooh,
does A kind of sound like? I think since you guys are going into this week, should have gone over. Yeah, pneumonia. What else might he have potentially?
Punchy bars. Man's just going circling down.
Possibly sepsis. Potential sepsis. Maybe you want to start the sepsis bundle on this guy. What's going on with B? What does
Eh,
B have? Pulmonary embolism. Yeah, so probably a pulmonary embolism. What about C?
I'm sorry, Ryan's response, I worry of PE.
Yeah, so this is acute epiglottitis. So wheezing stopped. So if this person normally had some wheezing going on and it suddenly stopped. Obstruction. He might just not, his airway might be entirely closed. And then D sounds just like hypoxia, right? So for this one, the answer is C. So again, in this situation, this is something that you might find on some test questions, Kaplan. When you see kind of like a person that's wheezing and then suddenly stopped, that pretty much means that that person's completely obstructed, airway is completely closed. So if we're going off ABCs, um, this one's more of the airway. The pulmonary embolism is a bit more of the breathing. This is more like a sepsis infection, so kind of more circulation, and this is more hypoxia, so breathing. So essentially, the wiggle room you have is going to be less with the full obstruction than with these people who are decompensating, but they have more wiggle time. They have more wiggle room, as opposed to this person who cannot breathe at all.
Yay.
Any questions? Cool. So this is something you're gonna need to do. I want you guys to interpret this ABG and include compensation. Is it fully compensated, partial, no compensation?
Man, he quick with it.
You might want to reword that, Donnie. We're on this. We're on number two. Okay, so let's break this one down. This pH, is it acidic, basic, within normal limits? Okay, so it's within normal limits. What's your normal pH? Cool. What about this CO2 level? It's high. So is that acidic, basic? It's acidic, right? What about the bicarb? It's high. So is that basic or acidic? Alkaline, yeah. And PO2, I know we talked about it a little bit above. Yeah, so it's a little bit low. So 80 to 100. So this is what we have. We have pH is normal, within normal limits. The CO2, I meant CO2, not CO, is acidic, and the bicarb is basic. So normally we want to be matching all these things, but because the pH is normal, we kind of have to break it down further, kind of in half. So anything that's on the lower end of normal, we kind of consider that as acidic, and anything that then is uh closer to, sorry, anything on the lower end, so like anything closer to 7.35, we consider that like more acidic, and then anything closer to 7.45 is closer to being basic. So by the fact that the pH is fully normal while the CO2 and the bicarbonate are abnormal, um you can kind of already determine that this is going to be fully compensated. So this is a full compensation right off the bat, as soon as you see the pH being normal and these two values being out of whack. Okay. And then because this 7.37 is closer to the low, the acidic part of your pH range, we treat it as an acidic value. So then we're matching acidic with acidic. Right, exactly. So if the pH was abnormal, then this would be partial. With the exact same scenario, this would be partial. So if this pH was this and every other number stayed the same, this would be partial compensation. This is respiratory acidosis because the pH and the CO2 are both acidic, so they match. So you match CO2, CO2 is respiratory. So if it had been 7.32, then this would have been a partial this would have been respiratory acidosis with partial compensation. But because this number was it was in normal limits, essentially your body fully compensated. It fully compensated, which is why the pH is back to a normal number. Okay. So review for sure your partial versus full compensation because you're gonna have to do that for your exam, okay? Yeah, and then kind of flipping the script here, because some of the things you'll see, so you'll see pH. Again, we went over how to interpret it if the pH is technically within normal limits. We split it in half, so kind of from 7.35 to whatever the halfway point, 7.4 would be considered acidic when within normal pH is within normal limits, and then 7.4 to 7.45 is basic when pH is within normal limits. So whatever side it's closer to, you consider it as basic or acidic for the sake of interpretation. Um, and then kind of flipping the script again. Typically with these, and you won't be tested on, I think, on your in class for this. If you had an in class, I hope it wasn't asymptom. I hope it wasn't asynchronous, but was it your lecture for this? Was it asynchronous? Kinda. Okay. So when we did this in-class lecture, Miss Salazar had some ABGs and one of the ones that came up, and you don't have to know it, it's called like a mixed either acidosis or alkalosis. So we noticed that the pH up above was normal, CO2 was acidic, CO3 was basic. But what would happen if your let's say your pH is normal, sorry, your pH is acidic, your CO2 is acidic, and your bicarb is acidic. That would be like a mixed, it's called like a mixed acidosis. It means that from both ends of the spectrum, you have acidosis. Typically, though, when it's not a mixed, then you will have your two values that match. Your pH will match with one of the two, and the other one will be the opposite. So in this scenario, the CO2 matched with the pH as being considered acidic, and the CO2 is basic. And then meanwhile, had this been respiratory alkalosis, for example, the CO2 and the pH would have been basic, while the bicarb would have been in the acidic range. So that's something to keep in mind. So in this scenario, we determined that this was respiratory acidosis with complete or full compensation. And that's how if I recall, it'll be a fill in the blank. So probably answer it kind of like that. And what could be causing it? What's something that could be an example of someone with respiratory acidosis with complete compensation? So for it to be completely compensated, probably a more stable patient, probably a chronic condition. So chronic condition that leads to respiratory acidosis. Yeah, yeah, for sure. COPD for sure. Sleep apnea, I'm not sure if it happens often enough for it to I'm sure it would be fully compensated, but I don't even know if the pH would be like that affected, but COPD for sure, like a classic example of this respiratory acidosis with complete compensation. All right, and I do have another one, another ABG that we can go over and practice some more. Number three, the patient in the previous question is having an exacerbation of their condition, which we, in this case, is going to be COPD. They became tachypnic and their SATO2 dropped to 84% had. The nurse then titrated the O2 on their nasal cannula to 6 liters per minute, and the SATO2 increased to 84%. So far, what do we think about this scenario? So, patient with COPD, their SATO2 was dropping to 84, and the nurse titrated the nasal cannula to 6, and the O2 went to 94. What do we think about that with a patient with COPD? Okay. The hypoxic drive. Okay. So then following that event, later, the patient is found to be obtunded, if you guys remember what that word means, and with bradypnea. The latest vital signs are blood pressure of 140 over 90, respirations of 6, normal temperature, heart rate of 120, SATO2 of 72%. Which of the following is your immediate actions? So what is your immediate action here?
Right.
And then what type of what type of condition is happening here? So this person is having acute respiratory failure. What is the origin cause of it? Is this ventilatory or oxygenation related? And in case people don't know what obtunded is kind of like you have lethargic. Even worse than lethargic is somnolent. So like they're really difficult to arouse. Like you talk to them and then they fall asleep mid-sentence. Obtunded is even worse than that. It's like the step between somnolent and a coma. So it's even more like barely barely active. So is this ventilatory failure or oxygenation failure? They had 6 liters on oxygen, yeah. But look at this here. And we talked about before about how people with COPD have a hypoxic drive. So that means that their bodies, so our bodies, our normal bodies without COPD, we breathe because the carbon dioxide levels are high. So we breathe to get rid of CO2. Someone um, with COPD, they have essentially chronic hypoxia to the point that, and like a chronic hypercapnia, so higher levels of CO2, their bodies essentially flip how they breathe, their respiration drive. And instead of breathing because CO2 is high, because it's always going to be high for them, it instead makes them breathe because their O2 is low. So in this scenario, this nurse titrating it this high caused them to stop breathing because the O2 levels were too high. So their bodies um deciding that it's kind of like a weird it's kind of like an ironic kind of thing where they got too much O2 which makes them not breathe, which then in turns means they're not getting enough O2. So this is more of a ventilatory failure because their body thinks they're fine. Their body went into like an apneic acute respiratory failure. They're not getting much ventilation. So because they're not really breathing very often, this 100% oxygenation is not really helping them because they're just not able to really breathe very often. Remember, your normal respiration should be twice this much, minimum twice of this, what they're getting. So with somebody that is having a ventilatory failure, that O2, high percentage of O2 is not enough because they're not breathing fast enough, often enough. So you need to do D. This person is going to need to be ambubagged because essentially it's like you're breathing for them. And possibly if they don't get better afterwards, they might need to be intubated. This is a ventilatory failure. And that 100% oxygen might also not be the most helpful thing because of their hypoxic drive. So really keep that in mind that the COPD people, too much O2 can make them bradypneic or even apneic. Yes, because they function off hypoxic drive, they function off their brain gets that higher percentage of O2 and they were like, okay, we're good. I don't really need to breathe. So that's the interesting thing about it. Any questions on this question? Does it all make sense? Because I spent like 30 to 40 minutes writing this question, making sure that all the values made sense and the situation made sense.
You menace.
All right. So now we're going to go on number 4. A patient comes into the ER after a near drowning event. How would you assess this patient? What are they at risk for? And kind of just a focus on like imagine you literally had someone ne nearly drown. How are you going to assess their ABCs? And maybe follow some of your BLS. They are at risk for ARDS, yeah. Gonna want to, yeah, lung injury, potentially lung injury leading to high inflammation, leading to ARDS. Vitals for sure. Is there a difference in treatment if this person has a pulse versus not having a pulse in terms of your BLS? So let's say this person has a pulse. This person that has near drowning event has a pulse. What is your initial action according to BLS? That could be one, yeah. Are they stable? Let's say they're not particularly stable, but they have a pulse. Okay, sure. So maybe some O2, something that the BLS recommends for, let's say they're unconscious. They're not conscious, but they have a pulse. Sure. Okay. I guess what I'm getting at is that for the BLS, if a person comes from like a near, yeah, you would definitely take all the vitals and stuff. The general idea is that for a person that is um after a near drowning event, if they have a pulse, you want to start with rescue breaths first. But if they don't have a pulse, you can do CPR. So you start with compressions instead. So your key thing there is if they have a pulse or not. And we mentioned they're at risk of ARDS because of the lung injury. But yeah, you would do all of those things. You want to see. I like the X-ray. Yeah, that's another thing. You can see how they're breathing. Do they have the equal chest rise? Do they have basically, yeah, you're assessing the ABCs, you're seeing how the respirations are. Do they have a pulse? Do they not have a pulse? And then your interventions change. So again, if they did not have a pulse, the BLS it says to give rescue breaths first. But if they did not have a pulse, then you do CPR, you do compressions. Does that make sense? So no pulse, compressions, just like how you've been going on for like the EKG lecture, no pulse, CPR, epinephrine, etc. If there is a pulse, consider rescue breaths. And yeah, and ARDS. Let me see what else I wrote on it. Let me see. Just so as always, the rationales are always going to be posted here. So here, assessment of the near drowning patient focuses on airway, breathing, circulation. If they have a pulse, rescue breaths. If the patient does not have a pulse, CPR. Assessing for obstruction, making sure they're actually breathing on their own. O2 or intubation if needed. You can monitor, check their lungs. They have risk for ARDS, and then everything else depending on their vital signs. So you guys mentioned everything here. Okay. So here's your next one, another ABG, and then kind of try to interpret what this is, and then we could ask what might be causing it. And then Ryan, is this a partial, no compensation, or full compensation? Because you will be asked that on your test. Okay. So let's break it down. Unless there's some of you that are still trying to figure it out, then just let me know. I'll give you like 10 seconds to respond. Otherwise, we'll just kind of move on to like the breakdown of the question. All right, so let's kind of go over it. So pH 7.5, we talked about the normal pH being up to 7.45. So this pH is basic. CO2, we said 35 to 45. So this is a low CO2. CO2 is associated with acidity and respiration. So this CO2 is basic. So we already have a match. And then the bicarbonate is, what's the normal range for bicarbonate? 22 to 26. Some places will, I've seen 23 to 28 as well for the depending on where it is. Point is, this is a normal one. So this is within normal limits. So bicarb is within normal limits. So we have a match. So we have basic with basic. We have basic here, basic here. So we know that this is some sort of alkalosis. It's CO2 again. So this is a respiratory alkalosis. Now, again, make sure you guys review your compensation stuff. This, because the pH is not normal limits, we know it's not a full compensation. But then the thing that determines if it's a no compensation versus partial compensation is by looking at this at the third number. So the bicarb, because it's at nor is a normal limit, this is actually no compensation. Okay, so that third value is kind of like the value that is fighting against the irregularity. So if this value is out of if this value, like kind of looking back here, this value was out of whack because it's trying to compensate for the whatever's happening. So the acidity in this case, it's trying to compensate. So because it's trying to compensate, it goes out of whack. But it did a good job compensating. So this number, the pH, goes back to normal value. Meanwhile, back down here, we have that alkalosis happening, and normally this is your compensatory. In this case, it's normal, so it's not really trying that hard to compensate. It's not really compensating at all. In fact, the pH then is out of whack, and the bicarb is not showing signs of compensation. And by what I mean by that is by being abnormal. By being abnormal, you're showing that you're trying to do something. It's basically normal and unbothered, so it's not compensating at all. Does that make sense? So this is respiratory alkalosis with no compensation, or you can say uncompensated. Okay. So again, it's all about looking at the third number for that one. So had this CO3 been compensating, it would have been because we have basic alkalosis, we have alkaline stuff happening. To compensate, this would have been at an acidic number. So we would have had this being like 20 or something. So that acidic number. And then that would show partial compensation. But because it's within normal limits, there's no compensation. It's unbothered. It didn't care to make itself abnormal. Okay. And then we talked about what could cause respiratory alkalosis, and I think let's see what we said. Hyperventilating, that's one that could happen. Yeah, for sure. Other things that might cause it, pain, anxiety, stress, technically like the start of an asthma attack for that brief period when you're hyperventilating. But yeah, generally that's the general idea. Okay. Number six, the nurse caring for a client who is mechanically ventilated is monitoring for complications of mechanical ventilation. Which assessment finding, if noted by the nurse, indicates the need for follow-up? Okay. What do you guys think is happening in C that has to do with mechanical ventilation? Yeah, the high PEEP. So if you have too much, if your PEEP is too high, you can have barotrauma. You can also have an increase in that thoracic pressure. You know, your lungs and your heart are right next to each other. So if there's too much pressure on the lungs, it can cause kind of squeezing or pressure on the heart, which would decrease your cardiac output. Yeah, so that could decrease your cardiac output and lead to a decrease in blood pressure because of your ventilation and most likely your PEEP being too high. All right, looks like that one's pretty easy for you guys. Number seven, you're providing care to a patient who is being treated for aspiration pneumonia. The patient is on a 100% non-rebreather mask. Which finding below is a hallmark sign that the patient is developing ARDS? Yeah, your keyword is remains there. Your PaO2 should be 80 to 100. And then this is kind of not changing, and it's going into that 50-50 to 60-60 rule. Your PaO2 below 50 with your CO2 above 50. This guy's definitely an indication for like intubation, or at the very least moving on from this to maybe trying the BiPAP CPAP. All right. Number eight. While caring for a patient who has been admitted with a pulmonary embolism, The nurse notices a changing in the patient's SATO2 from 94 to 88%. The nurse will do what? When it comes to pulmonary embolism, no, this is not a SATA. I'll reword it to the best course of action is when it comes to pulmonary embolism, is this leading to a ventilatory or an oxygenation failure? So what is being insulted when you have a pulmonary embolism? Yeah, your alveoli are being insulted from the lack of flow. So the issue is not that you can't physically breathe or get oxygen inside you. It's that the exchange is not happening. So pulmonary embolism is an oxygenation failure, as opposed to what we talked about before with that COPD patient who was having ventilatory issues. They might have been able to breathe effectively, like they could make their chest rise up and down, but because of the airway obstruction, well, actually, this is a different scenario, but like imagine someone with like airway obstruction, they might be able to breathe at a normal rate, but they might not be able to get as much oxygen out because the airway is obstructed, or because so think about like when you have a stuffy nose, you might be able to take a breath, but it not as much air is actually going through there because it's closed. Same idea. In that case, that person has a ventilatory because there's not enough going in, but the exchange is fine. Here, they have no issue getting air in. The problem is getting air to exchange in the alveoli. Yes, so we changed our answer here, huh? So in this scenario, the issue with this person is that they're having trouble exchanging oxygen. So the best option is actually going to be B, to increase the O2 flow rate, because unlike the other type, um, they're capable of actually breathing in and out enough to actually make use of the O2. Raising the head of the bed is gonna help with is gonna help a bit more with the ventilation part, but the absolute best course of action with someone with this is to get more higher flow of O2 so that to try to make up for the fact that their alveoli are not exchanging air as well. Does that make sense?
Yeah.
So that here we got to see the difference between the oxygenation failure versus the versus a ventilatory failure. So a ventilatory failure doesn't really benefit as much from a high flow O2. They benefit more from being intubated and having a CPAP, BiPAP, while oxygenation failure is going to help more from having a higher rate of O2 um, to try to make up for the inability to exchange because they don't have an issue breathing in and out. And they might still need to be intubated because that's how bad like the exchange is, where they need that direct as possible uh flow, but the general idea is there. Yes, the gas exchange is oxygen failure, while ventilatory is how much air you're actually getting in, which doesn't necessarily mean that their respirations are low per se. It just means the airflow is not coming in. So like I said, someone with obstruction, they might be tachypnic because they're trying to make up for the fact that there's not much air coming in because it's obstructed. You have um, that stuffy nose, for example. You're able to breathe in and out just as fast as normal, but there's just not much going in. It's very tight. It's a very tight fit. There's not much air actually going in. Okay, only two more. Number nine, a patient on a ventilator triggers a high pressure alarm. Upon assessment, the nurse notes that the patient is experiencing increased respiratory effort and has bilateral crackles. What is the most likely cause of this high pressure alarm? So what is a high pressure alarm?
Yeah.
Yeah, so what is a high pressure alarm? What does that represent? Blockage, yeah. Usually blockage or anything that puts pressure on the tube. So coughing can cause it temporarily. Any kinking, blocking of the tube. So that mucus plug, we know they have crackles already. So yeah, that mucus plug is the most common thing that can cause, like one of the most common things that can cause blockage in the tubing. Cool. And then
Yeah.
here's your last one.
Jesus.
So we have a 72-kilogram patient with COPD who is being weaned from mechanical ventilation following a COPD exacerbation. The nurse observes the following parameters during the weaning process. So this is their stats. Heart rate of 112, respirations of 28, O2 of 88%, spontaneous tidal volume of 280 mLs, blood pressure of 130 over 80, and this is their blood gas. Do you want to interpret this blood gas? Get one last practice in there, and then we'll move on to the final part of the question. Yeah, so again, we kind of already knew because it's COPD, but yeah. So again, we always try to match your pH with one of these values. So your pH, you immediately see that it's within normal values. So you can already, this is either going to be fully compensated or a completely normal ABG. Either they're normal or they're fully compensated right off the bat. Then we see the CO2 is high, which means it's acidic. So we associate a pH on the lower end to be acidic, even though it's within normal limits, because that's how you do it for the interpretation, because it's closer to acidic, so we consider it acidic for interpretation. So we already have a match here, but then we have to look at the bicarb to see if it's a mixed thing or not. The bicarb is high, which means basic. So here we see that we have respiratory acidosis, and we have pH that's normal, and we have a bicarb that's out of whack, meaning it's trying to do something. It's trying to compensate, which it did. So this is respiratory acidosis with a full compensation, fully compensated. Yeah. So if you were having trouble with this, make sure that you review the compensation. You don't want to miss the points on this one. So just make sure you just review that, okay? But
Yeah.
then moving on, but then moving on, so which all of these here, which finding indicates that the weaning process to be discontinued immediately?
Ew. Oosh. Ow.
Yeah, read the whole question.
No. Why you gotta do it like that?
What do you mean?
Why you gotta do it? Why you do them like that? That's not nice.
All right, this one stumped a lot of people.
You're not
Or,
nice. You stumped
we're
me. I'm sitting here like, ooh.
yeah, this one is there's discussion, not discussion, but there's what's the word? Different answers everywhere. I think we've had at least one of every answer choice.
I don't like this. I don't know the answer. Tell me the answer. Wait, I'm gonna check it, see if what I think is right.
All right.
This is hard.
Yeah,
I
say
don't even see. I'm in the. Oh,
yeah, if
queen.
you believe in C, don't say C question mark, say C period.
Yes. Yes.
Right. So let's take a look at this. So um let's look at A. So patient's heart rate is 112. That's definitely abnormal, but is it gonna make you want to wean them off immediately? Maybe not, especially when we think about um someone that's having, these people with COPD, they're not having the best time breathing. Their heart rate might be up as like compensation and whatnot. This could be partially their baseline. So it's something to look at and trend and think about, but it's not like the most immediate thing. B, O2 of 88%. What's the normal SAT O2 for a COPD patient? Yeah, it's expected. So think about your expected versus unexpected values. So again, someone with COPD, they can have uh their values can be abnormal like throughout the whole thing. They could have a bunch of abnormals, but it's normal for a COPD. So it's not just always about what's abnormal for like a normal person, it's what's abnormal for the person. So in this case, these two might be normal for this person that has COPD. And skipping C, the answer is C, by the way. We'll talk about C. We'll go to D first. D, the patient's PCO2 of 58. Kind of looking back at this other patient that had COPD, we talked about how this could be like a chronic, sorry, this is the wrong one. This one, chronic finding because this person's has yeah, it could be his baseline because a lot of these COPD people are going to be respiratory acidosis with complete compensation. You do. You do have to know their weight.
Yeah, right. Oh, bro, I totally didn't read the question. I got confused.
Right here.
I did
Exactly.
too,
I told
Josh.
you to read
I
the
missed
question.
that, and I missed the fact he was COP. I missed all of the top part. Realized that that was part of the question when I
Right.
read it.
So, but yeah, this CO2 is normal and expected for this person. It's not normal for a normal person, but it's normal for a COPD. Just like how back up here we saw that th this is just kind of what they're going to be like because their bodies are so used to their bodies just have a buildup of CO2. But then if we look at this 72 kilograms, remember your formula is they should be about 6 to 8 ml, not per hour, per kilogram. That would be a normal value for them. So if we were to take 672 and let's say the absolute worst, so times six, get 72 times six, 432. So they should be having minimum this 432. So this 280 is showing that they're not really able to get as much as they probably should. So what does the tidal volume mean? Tidal volume is how much they're actually breathing in. So we talked about this person with COPD, they're breathing a lot, right? They have 28 breaths per minute.
Yeah.
Um, but what determines ventilatory issues is about how much is actually coming in. Because these people have obstructions, because these people have obstructions, then even though they're breathing a high amount, not much might be going in because it's kind of like a hose, like HOSE. And the water flow, right? If it's more constricted, the pressure is higher and there's less coming out. So same idea, even though they're breathing 28, not as much air is actually getting through. And that's what the tidal volume um is. Tidal volume is how much is actually coming in, which we determine from their weight here that it's not enough. Make sense? Questions? Concerns?
Family problems.
What?
Yeah.
Cool, cool. And I think Kenan already gave you guys the file, but
I did.
I'll give you guys the file with the answers for that. I mean, you have the rationales here.
They were already all there.
Yeah. I guess you guys don't need it again, but here, yeah. Da, da, da. I guess here I use this file. We
Yeah.
get 6 to 8. But yeah.
Yeah, well, she married to the Muppet
So I'll give you
Man.
an updated version of that. Yeah, depending on where you go, different numbers. But yeah, 72 times 8, 576. Because that's the value we learned here. So yeah, so that's the things to keep in mind. And I will give it to you guys again though. But yeah, that's basically everything. Let us know if you have any questions. And then we'll definitely be seeing you guys for sepsis. And I will say, with sepsis is that some of the outside resources are going to be harder to utilize for that one just because it's a little outdated. So that 6 hour sepsis bundle is not really standard anymore.
Yay.
It's more of a 3 hour bundle. So if you're looking for outside resources, you might have noticed that difference.
Yeah.
But it's okay. We'll work through it together, and then you guys will be prepared for your test. And I just posted the doc. You guys will be prepared for your test. You will do just fine.
Thanks, guys.
Yeah.
Yeah. Oh,
And I'll see you guys tomorrow as well.
yay.